टेबल ऐसी है चलो ऐसे थोड़ा सा टेबल से इजी हो जाएगा. Good evening, everybody. First of all, I must thank the nice people for giving me an opportunity to interact with you all in this evening. I shall be discussing a very common topic, that's finding an answers to the management of atherogenic diabetic dyslipidemia. And diabetic, as you know, is very prevalent in this part of the continent. God has been quite kind to us insofar as the natural beauty, the environment, and various types of climatic zones which we have. But insofar as the lipid profile is concerned, there is very poor predictive power for coronary disease and diabetic in our population, because we are different from the other part of the world in the reason that our lipid profile has high level of triglycerides, LDL is not very high, and HDL is on the lower side. So these three components of the lipid profile in our population is known as diabetic dyslipidemia if it's occurring with the diabetes, or even otherwise also. So we were discussing that the nature is quite kind to us insofar as the environment and scenic beauty is concerned, but when it comes to lipid profile, it's very cruel in the sense that the triglyceride of our population is on the higher side, LDL is not very high, and the HDL concentration is on the lower side. So this part constitutes the dyslipidemia of the Indian population, or the South Asian paradox which we have. Now, apart from nature, the nurturing also matters, because we have now the culture of the pizzas and the finger fries and the various soft drinks, which also has added. So nature as well as the nurturing has contributed to more risk of coronary disease and mortality rate. If we see the lipid profile in the controlled population in the inter-heart study, if we compare with the European person, the cholesterol is not very high. It's, as compared to 203 in the European person, we have 184 milligrams of cholesterol, so it's on the lower side. HDL is also on the lower side as compared to the European population, so which is a harmful fact, and the LDL is not very high. So this kind of lipid profile, one would expect that the coronary disease would be on the lower side, but we have the coronary disease occurring 10 years before the European population, and when it occurs, the more number of vessels are involved as compared to the European. So lipid profile definitely betrays us insofar as the coronary disease is concerned, because these values are on the lower side, but the CAD risk is more in the Indian population. So typically a kind of case which we usually come across day in and day out is that a middle-aged person with a history of diabetes for the last 3 years, he has been on the lifestyle modification, metformin, glimepiride and statin for the last 3 years, and currently the LDL level is 90, not very high, and HDL is on the lower side and triglyceride on the higher side, total cholesterol 190 mg/%, and fasting blood sugar and the PP is a little on the higher side, 138 and 190 mg/%. So this kind of lipids, the triglyceride, LDL, is known as the diabetic dyslipidemia. Now, the frequently asked questions are, is the triglyceride, is the triglycerides a risk factor for cardiovascular disease or and acute pancreatitis? So is it, if it is high, whether it needs to be treated or not? If high triglyceride is to be treated, then what level of treatment should be initiated for prevention of cardiovascular risk as well as for prevention of the pancreatitis, acute pancreatitis risk? Then we have the drugs in the form of fibrates, and the latest which has come is the saroglitazar, which is there in the Indian market for last about 3 years. So if we are using, whether this is safe and effective, or and it's cost effective, and what is the right kind of patient for this kind of medicine. So coming to the first question, that is the high triglyceride a risk for the cardiovascular disease? Now, the South Asian paradox phenotype is that this is a very maybe thin individual with a high visceral fat, the LDL not very high, HDL on the lower side, and the high triglyceride level. This constitutes diabetic dyslipidemia. So, but this makes us prone for the insulin resistance, and the inflammatory markers are on the higher side. There's early beta cell destruction and early onset of diabetes, and high risk of diabetic complications. So, higher risk of cardiovascular events in a diabetic population is the end result of this kind of phenotype. Now, the ICMR study which is done, in 72% of our population we find that the main lipid abnormality is the low HDL, and about 30% they have the high triglyceride levels, and hypercholesterolemia is seen in about 13% only, and the high HDL is around 12%. So predominantly we are faced with the first three things: the HDL lower side, high triglyceride, and the LDL pretty on the reasonable side. Now, when the statins were introduced in 1987, then there was significant reduction. We had about 22% relative risk reduction with the use of statins, which are number one drugs for the prevention of coronary artery disease and secondary prophylaxis. When the more strong statin came, the torvastatin, the risk reduction increased to 32%. But look at the risk which is still present. So this is for the secondary prophylaxis. There are still about 60 to 70% of the patients of coronary artery disease who are still prone to risk despite the use of best use of the statins. So this is called the residual risk reduction initiative. That the 3 R are there. An initiative which is started in the Switzerland, that despite the best use, we don't have the best use of statins at the moment, but even in the best use of statins, then relative risk reduction, which is seen about 30%, and 70% of these patients are still requiring some form of therapy. And we know that the lipids are at the root cause of the atherogenic plaque, which is the main cause of coronary artery, the vascular disease. Now, loss of function mutation in ApoC3. Now, apoprotein C3, because different kind of apoprotein A, B, C, D, and D are there, and this kind of apoprotein C, which is carrying the VLDL into the circulation, if there is a loss of function, because apoprotein C prevents the degradation of triglyceride and the VLDL. So, if the apoprotein C is not there, there is a loss of function. Then there is a rapid breakdown of the very low density lipoprotein, and the risk of coronary artery disease comes down. So in a way, this kind of mutation is very helpful to the person, and this kind of mutation is seen in about 15% of the general population, and this might come sometime in the form of therapy, that we produce mutations by certain genetic engineering and then reduce the risk of coronary artery disease. And the fibrates also act at this level of ApoC3, and that is how they reduce the triglyceride levels. Now, the lights band kar dena. Now, the Copenhagen, which is the capital of Denmark, where the Copenhagen City Heart Study and the Copenhagen General Population Study was done, that these patients in that study, they had high risk of triglyceride. So the relative risk increased to about 5-fold with the increasing level from 1 millimole. 1 millimole is about 200 milligrams of triglyceride. So as it went on increasing, the risk of myocardial infarction increases in this population. And for the ischemic heart disease total, that is the coronary artery disease which is manifesting in form of stable angina, then this risk increases to about 3.2 times. So myocardial infarction rate increases with the triglyceride significantly, but CAD as it is also increases. So high triglyceride levels, they increase the cardiovascular risk by 3 to 5 times. Now, miracle study, which was sponsored by Pfizer, actually this study was conducted to see the high dose of atorvastatin, which is 80 milligrams per day, for the benefit of coronary artery disease patients. And when they studied their triglyceride thresholds, that starting from 135 milligrams to 195 and more than 195 milligram in the blood, they found that the relative risk of the coronary artery disease was more in this population. So age adjusted also relationship showed that the relationship of the triglyceride to the coronary artery disease was also was more. And in Tel Aviv, that's the Israel, they studied for 22 years follow-up of bezafibrate infarction prevention study, because bezafibrate fibrates came before that the statins. So they got a very long follow-up. When the 22 years ago they started the treatment of myocardial infarction patient with this medicine, they found that the hazard ratio went on increasing. If the triglyceride level of these patients were more than 100, then 150, 200, 200 to 500 and 500 more, the risk of coronary artery disease went on increasing, and it is in this group that bezafibrate was quite effective. So 22-year mortality risk of patients with severe hypertriglyceridemia was increased by to LDL and the VLDL. And now, simple mathematical calculation will show that these HDL can be excluded from the non-HDL cholesterol, and so LDL is primary cholesterol and the VLDL is a part which is contributed by the triglyceride. So if we have to calculate like we do in the simple formula, let's say non-HDL cholesterol is equal to LDL cholesterol plus 1/3 of the 1/5 of the triglyceride. So the LDL plus 1/5 of the triglyceride. So it means the triglyceride, they do contribute to the atherogenic plaques in the long run. So non-HDL cholesterol with the goal is 30 milligrams more than that of the HDL, though the goals have been really excluded, but still for the reference to discuss it, that the non-HDL level is 30 milligrams more than that of the LDL. So in the diabetes without cardiovascular risk, we accept that the LDL goal is less than 100 and the non-HDL would be around 130, less than 1. But if the cardiovascular disease is set in, then we will prefer to keep the LDL cholesterol still on the lower side, that's about 70 milligram, and the non-HDL cholesterol would be less than 100 milligram. Why I am discussing this thing is because this has become a very important component. It is very easy to calculate, because if we take the total cholesterol minus HDL, we find non-cholesterol, and this is an important marker for the CAD, and this is easy to calculate because we can send cholesterol at any time, no need of fasting, because patients don't have time. So even if they come in the evening, they can have a sample both for the total cholesterol as well as HDL. So it's very easy to do, and all the labs, they have started calculate, though we can also calculate. It's a simple calculation, mathematical thing. So the labs, they have started giving this non-HDL cholesterol because this has become an important marker for the treatment of coronary artery disease. Now, the non-HDL cholesterol and the cardiovascular risk, because LDL and the triglyceride, which are contributing to non-HDL, they are related to the incidence of coronary artery disease significantly. Now, what do the clinical practice guidelines say? Now, American Association of Clinical Endocrinologists 2017 have given the dyslipidemia guidelines. That is, the triglyceride should be part of routine lipid screening. So even if we get the non-cholesterol, this non-HDL cholesterol. So this is an important part of the lipid screening at least once a year, and moderate elevation more than 150 milligrams percent may identify the individual who are having insulin resistance, because insulin resistance people, they will have the triglyceride more than, so it becomes a sort of marker for the insulin resistance. And if the levels are more than 200 milligrams per deciliter, they may identify the individual with a substantially increased risk of atherosclerotic cardiovascular disease risk. And the triglyceride goals should be less than 150 milligrams are recommended. So normal is we take 150, 200 or 200 to 500, but here the goal for treatment would be less than 150 milligrams of triglyceride levels. And the Lipid Association of India Expert Consensus 2016 also recommends the same thing, that keep the triglyceride less than 150 milligrams, preferably less than 100 milligrams percent, and the triglyceride less than 500 milligrams. First achieve the LDL cholesterol. So this is a very important component of treatment, because we don't jump onto the treatment of triglyceride in the first instance. Even if the triglyceride on the higher side, first we try to achieve the LDL cholesterol to the target level, and if the triglyceride is still above 200 milligram percent, then calculate the non-HDL cholesterol, and if above the goal, add a non-statin drug. So statin is always there, add a non-statin drug to achieve non-HDL cholesterol goal. So in diabetes, we have fenofibrates and saroglitazide, and saroglitazide is a new entry into the market, which is a good option for the lowering the triglyceride levels. Now, European Society of Cardiology 2016 recommendations for treatment of hypertriglyceridemia. So drug treatment should be considered in high-risk patients with triglyceride more than 200 milligrams. So statin treatment may be considered as the first drug of choice for reducing cardiovascular risk in high-risk individual with hypertriglyceridemia. So even if the triglyceride are higher side, the first treatment would be with the statin, and then comes the treatment of the triglyceride level. So in high-risk patients with triglyceride more than 200 milligram, despite statin treatment, fenofibrate or the saroglitazide may be considered in combination with the statins. So drug treatment should be considered in high-risk individual with triglyceride more than 200 milligram percent. So there is a little variation, 150 and 200, but not much difference. So in high-risk patients with triglyceride more than 200 milligram, despite statin treatment, triglyceride TG lowering therapy may be considered in combination with the statins. So American Diabetic Association 2017 recommendations on triglyceride treatment. So that mentioned that statin and triglyceride lowering combination therapy is generally not recommended. This is reason because in 2013 the fibrates have been taken away from the FDA approval because the side effects of this combination was not at par with the benefits which was achieved. So this also really rectifies the states the same thing, that they should not be recommended, but the therapy with statin and TG lowering combination may be considered for men with both triglyceride more than 200 milligram and when HDL is also less than 34. So if this combination is there, then you can really combine. And patients with fasting triglyceride level more than 500 milligrams, then evaluate for secondary causes of hypertriglyceridemia like the thyroid disorders or other genetic thing, and the medical therapy should be given for the reduction of pancreatitis. So guidelines recommend that triglyceride more than 200 milligrams not controlled with optimal statin therapy. This is a very important component. So then this should be treated. Now fibrates or the saroglitazide. Now fibrates, as I said, in 2013 they were approved by the FDA, but then subsequently side effects really came, and that has been disapproved from the treatment of dyslipidemia only under special circumstances. The reason was that they increases the serum creatinine level, though it may be reversible. They change the liver enzymes, they produce myalgias and myopathy. The risk of gallstones is there, and especially when used in combination with the statin, because statin is an important component of treatment, then the fibrates, their risk increases insofar as the muscle dysfunction is concerned. and it doesn't improve the insulin sensitivity, which is seen with saroglitazar. So saroglitazar action is with the alpha and gamma PPAR, and serum creatinine, liver enzymes, myalgia, myopathy, gallstones, they do not really get affected, and insulin sensitivity improves, and TG lowering effect is more than that of the fibrates. So saroglitazar may be preferred in diabetic hypertriglyceridemia. So this is the first approved PPAR alpha and gamma, because this has got a dual action, predominantly alpha with optimal gamma action, and is approved for treatment of diabetic dyslipidemia and hypertriglyceridemia in type 2 uncontrolled with statin therapy. So it's a glitazar and it's not a glitazone, and so this is the reason we don't see the fluid and water retention with this molecule. So many trials have been conducted with the saroglitazar, so widely studied medicine, and with very few side effects like gastritis, dyspepsia, pyrexia, and asthenia. Those they are seen in about less than 2% individuals also, and even if they are there, they are very mild, and discontinuation of therapy is seldom required. And in the diabetic dyslipidemia, more than 3,000 patients have been studied, and this is quite lipid lowering, safe, well tolerated, and especially the 3-month study is also available. It reduces the triglyceride to a tune of about 35% and in 3 months time, and non-HDL level by 23.4%, and the HbA1c comes down by 0.9%, and weight doesn't increase, rather the weight is on the lower side with this medicine as compared to the other medicines. So we have got evidence for the saroglitazide, which is quite safe and effective, and it has been recently presented at many other forums. So it's a cost effective also. It has got PPAR alpha action, which is potent on triglycerides, and HDL may increase, and PPAR gamma action improves the insulin sensitivity and reduces the blood glucose, and it's quite safe thing as we have discussed. So when the statin therapy is not able to control the triglyceride level, because statins also control triglyceride to the tune of about 30% or so, but since there is still the residual risk of 70 to 77% with the use of statin, which is a very powerful medicine, so then there comes the need of the PPAR actions, the agents, and this recommendation is there from the various forums, like we have seen the American Association of Clinical Cardiologists and American Diabetic Association. So it acts at both levels of PPAR alpha as well as PPAR gamma, and is quite improving the health and wellness of the individual, and safety is also important, and we have quite safe medicine which is having a very least effect. That's the reason it produces smile on the doctors when they are dealing with a very innocuous medicine. So what is the right patient for saroglitazar? So patient which comes and has type 2 diabetes with dyslipidemia, and the therapy has been given, that's the lifestyle modification, anti-hypoglycemic agents, and optimal statin therapy, but still the triglyceride is on the higher side. So this is the kind of patient which will be required for saroglitazar. So if I am to sum up, that the triglycerides required treatment for the prevention of cardiovascular risk when it's more than 200 milligrams, and for acute pancreatitis when more than 500 milligrams, and it needs to be treated. And at what level we start the treatment? With the cardiovascular reduction, cardiovascular risk reduction is when triglyceride is more than 200 milligrams, or for pancreatitis reduction only when it's at 500 milligrams. So between the two, fibrates and saroglitazide, fibrates I have discussed that because of the side effect, especially when used in combination with the statins, and saroglitazide even high doses doesn't produce many side effects in combination also. So it's quite safe and effective. We have 11 years of research and 3 years of post-marketing experience, and it's quite cost effective because of its dual action of improving the diabetes control and the safety profile, and the kind of patient which you require is the type 2 diabetes with uncontrolled triglycerides more than 200 milligram with the use of statins. Thank you.